Good morning, colleagues. Thank you for joining us today on the second virtual SASTH conference. My name is Dr. Susan Louw. I'm just going to try and get my laser pointer up and going. So affiliated to the NHLS and to WITS, and I was asked this morning just to speak about von Willebrand's disease, a very well-known and a very common disease, just imparting a few facts relating to this disease process. The first case of von Willebrand's disease was actually described by Dr. Eric von Willebrand in 1926, and the index case was a very sad event of a 13-year-old female who bled to her demise during her fourth menstrual period. So definitely a disease process worth getting up for on a Sunday morning. So von Willebrand's disease is a bleeding disorder due to defective or inadequate von Willebrand's factor, which then manifests as mucocutaneous bleeding. Deep-seated bleeds into joints, muscles, and other organs can occur, but are not common. What then is the story around von Willebrand's factor? Well, von Willebrand's factor is a glycoprotein. It's actually multimeric. It's got various binding sites for example, factor 8, platelets, collagen, and for a cleaving protease called ADAMTS13. ADAMTS13 is tasked with breaking von Willebrand's factor multimers in the circulation into smaller, less hemostatic components. But this breakdown of von Willebrand's factor is a controlled, regulated process, always ensuring that there's adequate hemostasis. Von Willebrand's factor is produced and synthesized in the endothelium and the megakaryocytes and is secreted both in a basal and an on-demand fashion, always attempting to maintain hemostasis. Von Willebrand's factor then surveys the vasculature with hidden platelet binding sites at points where there is damage to the endothelium and there's subendothelial components exposed, for example, collagen. Von Willebrand's factor will bind, unravel, exposing platelet binding sites and forming a primary hemostatic plug, as well as initiating secondary hemostasis via factor 8. And defects in von Willebrand's factor then result in von Willebrand's disease. So we can think of von Willebrand's factor as the super glue of the hemostatic system. Von Willebrand's disease is a very common disorder. It is the commonest inherited bleeding disorder, affecting up to 1% of the population across all races, ethnicities, and genders. But accurate diagnosis and subclassification is still challenging because of the variability in the plasma von Willebrand's factor levels in the normal population. There are also multiple physiological functions of von Willebrand's factor, all of which can be defective, resulting in von Willebrand's disease. And there are still significant differences in consensus diagnosis and management guidelines across the hemostatic fraternity. And multiple variables will influence plasma von Willebrand's factor levels. Blood group O individuals, for example, have got low von Willebrand's factor levels, but don't suffer from a bleeding diathesis. And then various components and diseases and medications can increase von Willebrand's factor levels. For example, the pill, pregnancy, the circadian rhythm has an effect, and so does age. So a very complex, although common disorder. So von Willebrand's disease is a complex disorder, both as far as pathogenesis and diagnosis is concerned. The pathogenesis relates to various underlying mutations in the von Willebrand's factor gene, resulting in 3 main subtypes, as well as low von Willebrand's factor disease and platelet type and acquired von Willebrand's disease. Low von Willebrand's disease is diagnosed when the von Willebrand's antigen level is between 30 and 50, 50 being the lower limit of the reference index of von Willebrand's factor. So these individuals don't completely make the cutoff of being less than 30, which will result in the diagnosis of type 1 von Willebrand's disease. But von Willebrand's antigen levels that are in this range should result in the diagnosis of low von Willebrand's disease, as these individuals could manifest with significant bleeding disorders and should be treated as patients with von Willebrand's disease. The other three main subtypes is then type 1, 2, and 3, us as being coagulationists, being relatively straightforward, simple people, 1, 2, and 3, relating to various underlying mutations in the von Willebrand's factor gene. This can be summarized in saying that von Willebrand's factor defects results either in quantitative abnormalities or qualitative abnormalities, hence type 1 and 3 and type 2 disease, von Willebrand's diseases. Platelet type von Willebrand's disease or pseudo von Willebrand's disease relates to defects on the actual platelets that are unable to interact with the von Willebrand's factor in the patient. And acquired von Willebrand's disease manifests secondary to various underlying conditions, mainly malignancies. But we're also encountering this in patients with retroviral disease. As far as diagnosis is concerned, back to basics. So the family and personal history of bleeding should be elucidated in great detail. There are various scoring systems available in order to just remind the clinicians what questions to ask. For example, the ISDH bleeding assessment tool. ISDH is the International Society of Thrombosis and Hemostasis tool, which is depicted on the right here. And also there's a pediatric bleeding questionnaire, a menorrhagia specific questionnaire, and various of these clinical assessment tools are available. So this is important in order to investigate correct population for underlying bleeding disorders. And then we step into the laboratory where there are various assays available. These assays can be divided into baseline tests and specialized tests. The baseline tests, for example, include just a simple platelet count and then INR and activated partial thromboplastin time, von Willebrand's antigen and activity and factor VIII activity. Specialized von Willebrand's test assesses the ability of von Willebrand's factor to engage with various other components of the hemostatic system, including collagen, platelets, factor VIII. We can also analyze the multiple pattern in von Willebrand's factor and look at the von Willebrand's factor propeptide antigens. Various ratios are calculated, and the laboratory process is all in an endeavor to accurately subclassify patients with von Willebrand's disease. Von Willebrand's factor is an inherited disorder in the majority of patients, although it can sometimes be acquired. It's usually inherited as a dominant condition, can sometimes be recessive, but we don't frequently look towards genetic testing to diagnose von Willebrand's disease. Because this gene is a large gene, also containing a pseudogene consisting of inactivated DNA, making sequencing of this gene very difficult. The gene is also highly polymorphic with variability in normal individuals. Variants previously classified as pathogenic are present in the healthy people, and multiple different mutations result in the same phenotypic expression of a bleeding disorder. The DNA changes must always be correlated with functional von Willebrand's factor studies in the laboratory. And despite recent advantage, it is still unclear what exactly the utility is of genetic testing in von Willebrand's disease. May be helpful in selected patients, but there are still a lot of unanswered questions. What about pregnancy? Von Willebrand's disease definitely normalizes in pregnancy. Pregnancy and delivery of a baby being the most hemostatically challenging event in many women's lives. Yes, von Willebrand's disease does improve during pregnancy, but this is variable, and it is advocated that von Willebrand's factor levels and factor VIII levels be measured during the third trimester. A comprehensive multidisciplinary team should be established to care for pregnant patients that suffer from Willebrand's disease, and the treatment of these individuals will depend on the underlying type of Willebrand's disease that the patient suffers from. Treatment may be needed, is usually needed, and is definitely needed depending on the subtype of Willebrand's disease that the pregnant patient suffers from. Caesarean sections should be reserved for obstetric indications, and invasive management during delivery should be avoided because of the bleeding risk in the neonate. So what is the treatment of Willebrand's disease? The treatment aims to correct the dual hemostatic defect of low factor VIII and low or abnormal von Willebrand's factor. And this can be achieved either by releasing von Willebrand's factor from endothelial stores with a drug such as DDAVP, or by using replacement therapy, either in the form of human donated factor concentrates or factor concentrates that have been manufactured in the laboratory, termed recombinant von Willebrand's factor concentrates. This form of therapy is often combined with estrogen progesterone drugs in order to treat the menorrhagia, which is often a presenting feature in female patients that suffer from von Willebrand's disease, and antifibrinolytic agents such as cyclopentone are also often employed in the treatment of von Willebrand's disease. In summary then, von Willebrand's disease is a common but complicated bleeding disorder. Several laboratory tests at different time points are indicated to adequately and accurately diagnose patients that suffer from von Willebrand's disease. And multiple underlying pathogenic mutations are present, resulting often in the same phenotypic expression in patients. Clinical assessment of patients with a bleeding diathesis is paramount. Molecular biology techniques may change von Willebrand's disease diagnosis in the future, but its exact utility at the moment is not well defined. Von Willebrand's disease generally improves in pregnancy, but significant bleeding can occur. And von Willebrand's disease treatment entails both replacement of the defective coagulation factor or releasing additional factors from the sites of storage in the endothelial cells. Which brings me to my last slide, which is just a slide to say thank you. Thank you to the organizing committee for inviting somebody with many words to give a talk on a very complex subject in a very limited space of time. Thank you to the members of the audience for waking up early on a Sunday morning to listen to the talk. And thank you to the IT department or the technology savvy department that has made this virtual conference possible. Thank you very much. And I trust that you will enjoy the rest of the conference as well.